Well, look, it is 11:01. I want to be respectful of everybody's time. We got a lot of folks are still piling in right now, and so as they join, hopefully we'll just get everybody up to speed. So thanks again. Welcome back for everybody who's coming back after our last session. Thanks for all who are newly joining us. Just to revisit this, like, we're here for really one purpose. We're here to try and do whatever we can do to share knowledge, to ask questions, develop new questions, really brainstorm. This exchange is really helpful for me personally. It's helpful for a lot of us to reevaluate what we believe, right? To see if we know what we think we know and really ask the next question so we can do what we can do to minimize risk, reduce these injury rates, while also support our athletes who are seeking performance. And so that's why we're here. A couple of housekeeping notes. This Zoom call is going to last an hour. Certainly not more than an hour. If we wrap up sooner, then we'll wrap it up. But we're going to be respectful of everybody's time. You can see that there is a chat function, so we don't have the Q&A function like we had last time. So this is going to be a little more helpful to keep on top of the questions. But as you hear the presentation today, as you hear the discussion, please put some questions into the chat. This should be interactive. We're hoping to bounce things off each other and to learn and pick the brains of our panelists here. Anything that we can't get to, just like last time, we're going to collect. We're going to get together as a panel. We'll answer any of the unanswered questions, and then we'll recirculate to everybody who RSVP'd for this webinar. This will be recorded. We'll let you know how we're going to how you can access this and rewatch it. And yeah, with that being said, it's 11:03. Let's get started. So my name is Matt Ferree. I'm an orthopedic surgeon. I'm in Baton Rouge, Louisiana. I am a shoulder elbow sports medicine surgeon with a passion with taking care of baseball athletes. I did my training at Harvard for residency and at HSS for fellowship, where I was one of the assistant team docs with the Mets, helping take care of them when I was up there. And then now I'm down in Baton Rouge, Louisiana. I'm a team physician for LSU and passionate researcher for shoulder, elbow, and baseball sports medicine injuries. Enough about me. The panelists today, we're joined with a great group. So first up, Gunnar Brolinson, who is joining us, I believe, by phone, but should be here just shortly. Gunnar is a vice president for research, professor of family and sports medicine at the Edward Via College of Osteopathic Medicine. He's the director emeritus of the primary care sports medicine fellowship there at VCOM and at Virginia Tech. He's the former head team physician for Virginia Tech, past president of the American Osteopathic Academy of Sports Medicine, member of Olympic Sports Medicine Society, and a researcher and somebody who shares a lot of the same passions. So, Gunnar, anything else to add? I don't know if you can hear us yet. Not quite. He'll be joining us just shortly. So that brings up to our second panelist, Emily Ferree. Emily is a physical therapist. She's the founder of the Ferree PT Lab. She's got a ton of experience with professional athletes from multiple sports: NFL, MLB, NBA, MLS, NHL, really kind of covering it all. She's a certified manual therapist and really a biomechanics movement expert. Emily, could you tell us a little bit more about your passion, sort of what got you here? And yeah, share a little bit more. Anything I missed?
Yeah, my passion in terms of physical therapy really started with biomechanics and analyzing biomechanics, and in particular, 3D sports. So looking at things like pitching, overhead volleyball swings, stuff like that. And so I really kind of grew a passion for throwing and pitching specifically, and kind of flew myself around the world to learn biomechanics, because it, in particular with pitching, because it wasn't something that came typically with school with PTs, and then started working with some teams and some baseball performance individuals, and we built out a baseball performance lab and have been studying pitching biomechanics ever since.
Great. Well, thanks for your passion, all the work that you're doing. That brings us to the next panelist, Mike McFerran. He is the pitching coordinator for the A's, pitching lab coordinator in the development of player development at Wake Forest previously from 2021 to 23. Really, he's on the forefront of the science, data, technology to improve baseball pitching performance. He was one of the creators of the Wake Forest Bridge Seminar, which over the past couple of years has just continued to grow and been a great exchange for some of the brightest minds around baseball. Mike, anything else you want to add or tell us a little more about your story and background?
No, yeah, I'm happy to be here. I've known Daryl and Adam for quite a while and their work. I think it's revolutionary on trying to stop these injuries from happening in the elbow. And I think it's, something that is really pushing the foreground, like you said, of how to keep elbows safe. And it goes hand in hand with player development, which is very cool. So hopefully I can add something from the on-field side of things, in addition to the PhDs that I'm surrounded by here, which I, of course, don't have. But happy to be here and hopefully can add some value.
Great. Thanks, Mike. And then it brings us to our presenters for today. So Toby, Addis, and Drew Hagen. Both Toby and Drew are third-year med students over at the Edward Via College of Osteopathic Medicine. Toby's the 2027 class president. He's got a master's in public health and a master's in biomedical sciences. And then Drew, he's got a bachelor's of science in biomedical engineering. Was magna cum laude of his graduating class. Toby, Drew, do you want to share a little bit more about your background before we load up the presentation and get going?
Yeah, absolutely. Thank you, Dr. Fury. Yeah, I think most of my sports background really actually doesn't come from the pitching world. My sports medicine background actually comes from snow sports. So I've worked as a National Ski Patrol Alpine Ski Patroller for several years, a mountain travel and rescue instructor, and also in the EMS sphere, of course, plenty of traumatic injury there. But I'm really excited to step into the world of sports medicine and the pitching sphere, and it's been really interesting thus far, and I'm really excited to keep moving in the sector.
Awesome. What about you, Drew?
Yeah, not as much experience as Toby in the realm, but through going to VCOM, through Dr. Brolinson, as well as some of the current team positions there, I've been fortunate enough to be on the sideline for many of the Virginia Tech sports teams, learn a lot about where it goes and how it works day to day and stuff. And it's really inspired me with a lot about sports medicine. And I think it's really cool to be able to conduct research and learn more about it to help, find some answers and hopefully provide some solutions into the future.
Perfect. Well, look, why don't you guys load up, start screen sharing, load up your presentation. Toby and Drew are going to give us a presentation today on a study that they've been doing looking at forearm flexor strength and the association with UCL injury. So, Toby, Drew, take it away. We'll move through your presentation, and then after we're done, we're going to open it up to the panel.
Awesome. Thank you so much, Dr. Fury. Yeah, thank you to everybody that can make it here today. Good afternoon. Drew and I will actually be talking about a little bit of research we've been working with Dr. Fury, Dr. Brolinson, many others. And what we've been doing is exploring the correlation of forearm flexor strength and imbalance with UCL injury risk. So we've already talked a little bit about ourselves, so we don't want to gloat of ourselves too much. But like Dr. Fury said, and Drew are both third-year medical students at the Edward Via College of Osteopathic Medicine. My background comes from starting off at UVA with a BA in biology and then a Master of Public Health at the University of Virginia School of Medicine, and then moving over to VCOM for that biomedical sciences master's. And here we are now, med student trudging along.
Yeah, that's awesome. And I'm really happy to be here. Glad for everyone who's able to make it. And yeah, I completed my undergrad at Virginia Tech, and I was fortunate to stay in Blacksburg, to stay at VCOM, and continue this journey there today. And so here's just a quick objective. So we're going to talk about muscle imbalance first, as well as some anatomical relationships of the UCL. And then I'm going to hand it back over to Toby, where he'll give us an overview of our study titled Neuromuscular Imbalance in UCL Injury. We'll have a brief discussion and some conclusions, and then we'll open it up for some questions. Okay. So to begin, we will talk about what is muscle imbalance. So muscle imbalance can be defined as muscles being unable to properly perform due to being over-lengthened and weakened, over-shortened, or fatigued from overactivity. And some examples listed here include left versus right muscles, anterior versus posterior, and flexor versus extensor. Of course, we would expect certain athletes to have inherent muscle imbalances in left versus right limbs due to dominant sides or even due to the nature of the sport playing position, such as pitchers having a stronger pitching arm. But when we look into muscle imbalances and how they impact UCL loads, we look at different muscle groups within the same limb that work synergistically with each other to perform a specific movement, such as the forearm flexor muscle group. So muscle imbalance can have significant impacts on baseball athletes, especially in pitchers. Athletic performance in baseball is a common source of muscle imbalance due to the repetitive, sport-specific movements that often favor certain muscle groups over others. When athletes consistently train or compete without equally strengthening synergistic muscles or their opposing counterparts, imbalances can develop. These imbalances not only limit range of motion, strength, and movement control, but they also increase the risk of injury as the body compensates by placing undue stress on associated joints, tendons, and ligaments. Over time, these issues can hinder performance, delay recovery, and potentially even shorten an athlete's career. So the forearm flexor muscle group provides important protective effects to the ulnar collateral ligament or UCL, especially when performing repetitive throwing motions. The group includes the flexor digitorum superficialis, the flexor digitorum profundus, and the flexor carpi ulnaris, each of which can be visualized on the image on the left side of the screen. These muscles are found on the medial side of the forearm and feature an origin in close proximity to the UCL, which can be visualized on the image of the right. Studies have shown that these muscles can compensate the large external valgus torque experienced by the medial elbow during pitching through dynamic stabilization of the forces across the medial elbow, which helps reduce strain on the UCL and absorb or distribute valgus loads that would otherwise be transmitted directly to the ligament itself. So, in order to confirm these anatomical associations of forearm muscle tendons at the UCL, a fine wire electromyography or EMG study was conducted at the VCOM Virginia campus. The results of the study confirmed the anatomical association of the forearm flexors with the UCL through demonstrations of flexor digitorum superficialis targeting during mid-finger flexion and flexor carpi ulnaris targeting during ulnar deviation. Furthermore, it was also demonstrated that a flexion force from distal attachment applied roughly 60% more stress to the flexor digitorum profundus than the flexor digitorum superficialis. So with that, this leads us to believe that although despite rarely being studied, the flexor digitorum profundus may also play a vital role in protecting against distal UCL tears. And so the findings from this study confirmed the anatomical association of the three previously listed forearm flexor muscle tendons at the UCL and progressed us to our research project.
All right, so now we want to dive into what we did together with Dr. Brolinson and Dr. Ferree, which was our retrospective cohort study on neuromuscular imbalance and UCL injury. So we felt that it really was important to focus in on neuromuscular imbalance specifically. And there is previous research, for example, a study out of the University of Florida that found that 52% of patients with a UCL injury also had a forearm flexor injury. There really was a substantial lack of research that examined the potential contribution of muscle strength imbalance towards the mechanism of medial elbow injury in pitchers. So that's what we aimed to look at. So as far as study design goes, this was the overarching methodology we can see here that we developed to explore the research question of how that muscular imbalance in the forearm flexors was correlated to UCL injury. So now we could go in and dive into each portion of the methods here and see how it all shook out. So we start off with our data collection. Data on flexion strength was collected using the Flex Program device, which was uniquely suited for this application simply because it has the ability to isolate fingertip flexion strength and mid-finger flexion strength. And this is done by adjusting the finger receivers on the Flex Program device, and they can either engage the distal phalanges or the middle phalanges, and then the subject would be instructed to flex 90 degrees of the shoulder and then 90 degrees of the elbow, and that can be seen in the image here on the right. Under the supervision of a trainer, the participants of our study were instructed to perform a 1 rep max isometric flexion of fingers 2 through 5 for a total of 3 seconds. And then the device would automatically record the highest force input received at any given point within that 3-second frame. And that was basically what was the study measure that we were recording. So after we did that with all the subjects and collected all the data, we could actually take a look at what we collected here. So the left side chart would actually be our injured cohort, and our uninjured cohort is here on the right. So after we collected that data from the subjects, we also collected a history from them about upper extremity injuries. And if they met the criteria in our study, which was medial elbow injury within 3 years of the reading, they were included into the injured cohort. Now, the data points that we specifically collected from each of these participants was a 4-finger fingertip flexion strength, 4-finger mid-finger flexion strength, and then we also calculated the mid-finger over fingertip flexion ratio. For the injured cohort specifically, the types of injuries that we saw in the study, they can be seen here in this right column of the left table. They included sprains, strains, pain, tears, and repairs of the UCL or associated flexors, and pitchers that had no such history of injury were recorded in the uninjured cohort here on the right. So once we collected all of that data, we performed a 2-sample t-test. After verifying the test assumptions, we did that utilizing RStudio for all of our statistical tests. The assumptions of normality and equal variances were verified using the 2-sample F-test and the Shapiro-Wilks test, respectively. We then also performed a 2-sample Mann-Whitney U-test simply for robustness, but what we found was actually that the t-test and the Mann-Whitney U-test, or the Wilcoxon-Rank sum test, found statistically significant p-values for the 4-finger fingertip flexion strength, the 4-finger mid-finger flexion strength, and then the ratio of mid-finger over fingertip strength. And you can actually see the outputs of the R algorithm here on the bottom for those 3 test statistics. So what did the results look like? So here we can actually see the p-values for each of the groups from the 2-sample t-test, which showed a 0.03 for the fingertip flexion strength. And then for both the mid-finger flexion and the mid-finger over fingertip flexion ratio, the p-value was actually less than 1,000. This table here at the bottom actually shows the an output for our cut point analysis. The cut point analysis essentially looks at the different cut points that we could theoretically use for using this test as a diagnostic or predictor. So this is essentially an output of sensitivity and specificity for the test and how that changes if we change the ratio cut points here on the left. So a little bit about what we found. So our findings, like we said, our p-values are extremely significant. The results of the statistical analysis actually suggest that there was a measurable correlation between mid-finger and fingertip flexion strength with pitching associated injuries in baseball pitchers. An underlying mechanism when we were diving into literature about this that could explain this phenomenon is that the relatively lower mid-finger flexion strength in the injured cohort indicates that the flexor digitorum superficialis is actually unable to provide as much muscular support to the humeral ulnar joint, and therefore that would dispose the ulnar collateral ligament, or UCL, to experiencing higher stresses. The fingertip flexion strength discrepancies between the injured and uninjured cohorts indicate that the flexor digitorum profundus was also lacking in providing that protection against distal UCL tears. When we also looked into the literature, we found that this mechanism was corroborated by findings from actually research out of Japan by Ikezu and their colleagues that found that 89% of the participants in their study with combined UCL and flexor pronator muscle injury had identifiable injury to the flexor digitorum superficialis. So when we actually go down here to this table again, this is the same table as seen in the previous slide, we see that if we utilize the mid-finger over fingertip ratio as a predictor of medial elbow injury, there is actually a very promising utility of this tool at the 0.89 cut point. So we figured that the 0.89 cut point out of the analysis yielded the highest utility, and that's because the sensitivity there was at 100%, or 32 out of 32 for our sample. And then the specificity was also exceedingly high at 92.86%. And that provided the best combination of utility and use for this test as a predictor or a diagnostic. So when we look at grip strength dynamometry versus isolated flexor dynamometry, we found that there was a significant importance to what we were doing in our research, simply because grip strength testing, which has been widely adopted in professional baseball as a practical measure of local muscle function relative to elbow stability, has existed for a long time, right? And it has a very high test-retest reliability in populations musculoskeletal conditions, but it primarily measures combined force output of multiple forearm and hand muscles. And that really shows that there's a lack of distinguishment with the contribution of individual muscle groups. So in a clinical context, that's really important because where there might be specific muscle imbalances present, overall grip strength may remain within normal limits, and they might mask the deficits that key stabilizing muscles that are relevant to injury risk, right? So by having that combined force, you could have compensation that provides a masking effect. Whereas with isolated flexor dynamometry, we have the ability to actually look at specific flexor groups and measure those imbalances. And we believe that finding those muscle imbalances can significantly undermine the reliability of grip strength measurements.
All right. So now, looking at our results versus hand grip dynamometry, I think Toby did a really nice point by talking about how, through our research and such, we found that muscle imbalance can significantly undermine the reliability of grip strength measurements. And in a July 2024 study titled, "Is There a Relationship Between Grip Strength and Injuries in Professional Baseball Players?" Which involved, I think, 213 pitchers, researchers concluded there was no significant difference in mean grip strength or change in grip strength as measured by a hand grip dynamometer over the course of a single baseball season between pitchers who sustained a shoulder or elbow injury and those who did not. And this was likely due to the fact that the strength measured by the hand grip dynamometer is based, as Toby said, on the combination of the strength of the FDS and the opposing strength of the palm and thumb, with the palm and thumb having really no real role in protecting the ulnar collateral ligament. And additionally, when measuring strength on the handheld dynamometer, users are in a nearly closed fist position, which places the FDS at its near end range of motion, creating a distorted length tension effect that is markedly different from what a pitcher actually experiences at max layback when torque on the medial elbow / UCL is at its peak. And so why was flexible grip optimal for our study? So to begin, the flexor detorum superficialis and flexor detorum profundus muscle tendon units are very difficult to isolate and target. And like we mentioned, the flexible grip device can perform isolated dynamometry, but also importantly to us, it has the benefit of measuring the flexors at their long muscle length, like completely outstretched, rather than their shortened length as hand grip dynamometers do. While measuring flexion was the most important considerations for our study, the flexor grip also has the capability to measure extensor and wrist deviation. Those features, combined with the ability to objectively quantify load from specific muscles, made it the ideal device for our project. And so the question remains whether forearm flexor weakness precedes injury or whether injury can lead to forearm muscle weakness. The nature of the retrospective cohort study does not help address this specific issue, but while it's certainly possible, the high correlation between those who had relatively weak flexor detorum superficialis strength and prior UCL injury leads us to believe that there is currently no good reason to not proactively have any pitcher with flexor detorum superficialis strength train to boost their FDS strength and or stiffness, especially when you couple this with Jessica Geiger's recent Wake Forest study, which found that pitchers who trained on flexible grip for 10 weeks experienced a 43% decrease in medial elbow gapping. Additionally, several other research studies have found that roughly 50% of the time a pitcher tears his UCL, he also suffers a flexor tear, and 90% of the time this involves the flexor digitorum superficialis. So it seems rather obvious that a weak flexor digitorum superficialis puts both that muscle and the UCL at risk of injury.
All right. So what do we conclude from these statistical findings? Well, to concatenate those findings, the results from our statistical analysis simply demonstrated a measurable correlation between mid-finger and fingertip flexion strength and throwing associated injuries in pitchers, specifically UCL injury. So it's important to mention that there were some limitations of the study that we encountered that included having a relatively smaller sample size. We had an N of 74, and it only included pitchers, right? The heterogeneity of injuries experienced by that injured cohort was relatively wide. Of course, we limited our inclusion criteria to specifically include injuries that are relevant to the UCL humeral ulnar unit. But having higher precision on injury types could possibly help pinpoint findings on which types of injuries are most causative. So with that in mind, we think that future work should focus on increasing those sample sizes, including research on other myotendinous units crossing the humeral ulnar joint, for example, the flexor carpi ulnaris, amongst others, and prospective research on UCL injuries following flexor strength measurement could help distinguish that temporal relationship that Drew was talking about between weakness and injury, or injury and weakness. So, what are our thoughts? So, simply put, the diagnostic and predictive benefit of this device and also measuring forearm flexor weakness seems to have a really promising avenue. At this current junction, without prospective research on the predictive value of these measurements, the device can either be used as a diagnostic of injury, and that would happen if the case was that injury precedes weakness, or if weakness precedes injury, this could really be used as a predictor, right? So regardless, the specificity and the sensitivity of the test, as demonstrated by that cut point analysis, is exceedingly strong. And because of that, we think that there is significant utility in either regard, if you want to use it as a predictive device or a diagnostic device. So in the case of strength training, our findings suggest a nearly irrefutable benefit to focusing on forearm flexor training in order to strengthen that humeral ulnar musculoskeletal structure. Utilizing isolated flexor dynamometry to track strength progression and then utilizing that data to focus on reducing imbalances should really provide a protective benefit to pitching athletes. We hope that future research will help to confirm that temporal relationship of weakness to injury or injury to weakness. But at this current junction with what we know, strengthening the FDS and the FDP should really be a priority to help reduce the prevalence of UCL injury in baseball pitchers.
Yeah, and just to add to that, I think Toby said it beautifully. I completely agree, but really I believe that no matter which way you think of it, forearm flexor muscle imbalance and UCL injury are intertwined and highly correlated, and regular targeted strengthening of the forearm flexor muscle group ensures these muscles are prepared to provide protective support before issues arise, making them an important preventative strategy for all pitchers aiming to avoid UCL injuries. Importantly, strengthening the forearm flexor muscles is low risk and targets the natural stabilizing capability of the forearm on the UCL. And unlike some other potentially like high intensity or complex training protocols that can strain joints or compromise them, these targeted movements build functional muscle to aid in injury prevention and improve performance, making them suitable for athletes at any level without really introducing any new risks. And before we wrap up, we just wanted to have a couple of acknowledgments. We would like to express our sincere gratitude to everyone who played a vital role to this research project throughout its development, including Dr. Brolinson, Dr. Redden, Dr. Ferree, Dr. Rogers, Dr. Kozar, and of course, Dr. Ferree.
Drew, Toby, thank you so much for taking the time here for a great presentation, for sharing everything that you guys have been working on. Just some quick thoughts for me, and then we'll bring to the panel and pick the expertise of our great panelists here. I think one important thing to highlight is like you said, this was a retrospective study that determined association, right? And so in the retrospective study, we found that there was an association between FDS weakness and UCL injury, and that ratio of FDS to FTP, right? And so the next step here is really a prospective study to where you have from the outset you have throwers who are either FTS FTP balanced or FTS FTP unbalanced, and then we follow them longitudinally, right? And so that's the best way to do good science and take that next step. But to your point, Drew, kind of when you're wrapping things up, it's hard to necessarily sit on the sidelines with the data that we have now and not do anything. And so for me personally, clinically in my throwers, I'm using strength benchmarks for both the FTS FTP and the ratio of FTS to FTP strength in my return to throw determinations, like my objective testing battery, and in my post-operative protocols too as well, because I think we saw from Jessica Geiger's work and what she presented last time we did this about how this is trainable, right? And we see a measurable difference in joint space gapping, right, with a training intervention. And so for me, I think it's low-hanging fruit to attack, from the surgeon patient counseling side of things. But the next step, though, for good science would be doing a prospective study, which is what we're going to try and do here. Thanks again. I'd like to get Mike and Emily. I don't know if Gunnar has gotten to a spot where he can chime in quite yet, but Mike, let me call on you first. Initial thoughts, just after hearing Toby and Drew. What are your big takeaways from this?
Well, it was great, and I think it just becomes so obvious when you see it, right? I mean, forearm is weaker and can't hang on to what we're being tasked to do it with, and you guys are adding actual information to that. So, on my end, it's much less about figuring out, I think, what exactly the problem is, and more about like applying a solution to it in real time, which is, I think, the next step. And in my perspective, and I think I can come from a slightly different one because I'm surrounded by so many people with an academic background, and I'm more of an on the field, type of personnel. But it's about that transition, and it's about helping people understand, okay, what is actually the issue in normal language, right? And just the usual language that people use. And I think that baseball coaches use a much different language than, you guys do. And for me, it's about translating the issue and about understanding it, and then about making sure that so many different parties who are involved in the player development process understand what's going on and how to actually apply it within our system. So I think breaking it down in this way makes it much more simple to understand, so that we can actually make those steps into actually applying it. And that's really huge.
I totally agree. Emily, what are your thoughts after hearing Drew and Toby's presentation?
Yeah, I love the presentation. Thank you guys. Some really exciting work. And I think my big takeaway is just the importance of specificity. Obviously, we've known in both the baseball rehab and sports medicine side and the baseball performance side that the strength of the forearm is important, but being able to narrow down exactly which musculotendinous units are at play, and then knowing that the length tension relationship that we train them at and the positions that we're training them in are so important. And, we talk about in physical therapy all the time, don't guess, measure it, and being able to actually measure, where these guys are at per how hard they are throwing, and have these benchmarks, kind of like you mentioned, for return to play decision making to get them back out there. But I think just the main point is that not all forearm training is equal. And if we aren't training in those specific ranges at those specific, length tension relationships that guys need when they're pitching, that we aren't necessarily targeting what we need to be targeting. So specificity is so important.
Yeah, Absolutely. And real quick before we go any further, we had a comment from the chat, which is also really important to lay out there and to state with regards to the study, how it's conducted, and also conflicts of interest, which are important to disclose as you're having these discussions. And so for me personally, I'll say I have no conflict of interest with the company or with the equipment that was being tested in this study. Certainly no financial conflict of interest. I would say that my conflict is the fact that this is something that I'm passionate about, and I do think that the folks that are behind the implement that was used and tested are also passionate about trying to do whatever we can to learn further and to help overhead athletes. And so for me, I've got no financial relationship with the company. I do help with some research side of things, and a lot of that is independently spurred, so not necessarily questions they bring to me, but questions that I or others generate and then use some of their equipment. But Mike, Emily, just can we disclose any type of conflicts that you may have related to our discussion here today for our viewers?
I would say I have no conflict of interest. I have no financial relationship with Flexport Group or the company, and no prior relationship with your academic institution either. So no disclosures for me.
Yeah, same with me. It's the first time I've met the three of you outside of Emily on this panel. So, and then on the Flex Pro Grip side, just a very big just supporter of those guys and what their vision is, but certainly without any kind of financial.
Gunnar, are you available yet, or if not, we'll keep going. So look, just to echo what Mike and Emily said, for me personally, I completely agree. The granularity of the data that we're getting here is important to take that next step, right? We've known that the flexor pronator group in general is critical, right? It's critical for supporting the underlying ligament, for dynamically stabilizing the medial elbow. But what does that mean? And so by this study, we highlight that we can get granular data and we can attack weaknesses in a very specific way. And to Mike's point, like I use numbers because I feel like my athletes want to have we're in the gaming world. They like to have a score. They like to have something that's in front of them to go off. And so I use it from the rehab side of things or the return to throw side. Again, maybe I'm putting the cart before the horse with regards to these numbers and the potential preventative way and the prediction of risk. But I just say, look, hey, here's the numbers. Here's where you are, and you're weak. Look at this number compared to this number. I need you to work on this. And I think that athletes really internalize that, and they appreciate having a score and having some objective data. And so that's how I use it clinically. Now we're getting some questions in the chat. Thank you for all who are putting in some great questions here. We're going to start moving through. We're going to simulate some discussion. Anything that pops up, please throw into the chat. So for Toby and Drew, just we had a question. Can you review inclusion exclusion criteria, how we got these two cohorts, and also the timing of data collection relative to their injuries?
Yeah, absolutely, Dr. Ferree. I can touch on that right quick. I think I scrolled through some of the questions here, and I think I saw inclusion criteria as well as like where that sample was obtained from. So I feel like I can knock those two birds out with one stone right here. Simply put, so these individuals, the participants in our study, they were collected. The information was collected from players or pitchers that came from Driveline and 3 D1 colleges that utilize the FlexPro grip and have trained trainers that know how to utilize that device in order to enact our study protocol precisely. So that was where we collected our cohorts from. Now, the specific inclusion and exclusion criteria, the inclusion criteria was going to be for the injured cohort would be a primary playing position as a pitcher and a medial elbow injury within 3 years of flexion strength reading for the injured cohort. So that medial elbow injury had to be a sprain, strain, tear, recent surgical repair, or adjacent joint pain. So that was the inclusion criteria. And then exclusion criteria would be any sort of upper extremity injury that really had no direct impact on the flexor group or the UCL specifically. So for example, like an olecranon fracture, that would have led to you being excluded in the study. That was one specific example. And then, of course, all that information is de-identified. But that was going to be like our sample or where we collected that sample from and who was allowed to participate in it.
And Toby, it's important to, that's the inclusion criteria, and the inclusion criteria can affect your interpretation of the studies, right? So the injury designation was within 3 years of the testing. And so that brings up the question, are these findings, are these positive findings because these athletes after an injury or after a surgery are just not quite back to normal yet? So if there was a larger time range for the inclusion criteria, or maybe if we follow these out over time, it's possible that these things normalize, right? But we know that guys coming back from UCL reconstruction at the first year are not really back, right? If we get granular and we look at performance metrics, they're not quite back. It takes them longer to that 2 to 3 year mark for some of the stuff to normalize. So it's possible that we're catching them on the downslope of their injury or surgery and that they will get stronger down the line. So important to highlight your inclusion criteria may affect the interpretation of the findings.
That's exactly correct. Yeah.
Another question was, did you look at velocity, age, competitive level between those two cohorts? Are we comparing apples to apples with the injured guys, 98-mile-an-hour throwers versus 89-mile-an-hour throwers in the uninjured? Give us a little more detail there.
Yeah, that's an excellent question and super important to consider. With our samples being relatively larger, so with a N of 32 and 42 for the injured and uninjured cohorts specifically, we did not standardize across pitching velocity or age, but given that our sample was strictly taken from driveline pitchers as well as D1 pitchers, we were basically operating on the assumption that the participants within those locations or within those organizations were pitching obviously at a certain competitive level and therefore standardized within the sample. There was no one-to-one matching as far as age or velocity. And I think I also saw somebody bring up a question about body mass. That was not a one-to-one match on that either, but it was simply just a matching as far as the sample was coming out of the same locations or organizations for the injured and uninjured cohorts.
So Toby, Drew, to take that further, you might want to, in the next kind of rerun of the stats, get some demographic data and make sure that you can present demographic data of the two cohorts so the readers can understand if there are baseline differences for starters. This is a great Emily question here. Emily, hearing this research, how does this apply to other sports besides baseball? As somebody who trains a wide variety of athletes, what are your thoughts on incorporating these findings into your practice?
Yeah, that's a great question. And I actually use, so I own a Flex Pro grip device. I bought it full price and I pay full price for all my subscriptions for all my athletes. But I use it actually a lot with my NFL players. People don't talk about this nearly as much, but UCL tears are not uncommon in the NFL, especially with defensive players. So guys who are tackling, a lot of linemen, linebackers, and I've even had some defensive backs who've torn their UCLs as well. Now in football, we really never surgically repair them, but a lot of times you'll see guys just go out and play with those giant elbow braces. So I have 3 guys on my patient roster right now that do not have UCLs, full grade thickness tears, and they're back playing, and we use the Flex Pro grip to test them. And interestingly enough, we find all the same strength imbalance patterns that we do with pitchers who have had UCL injuries. So primarily the FDS, mid-finger flexion tends to be the weakest. And so we use the Flex Pro grip both to rehab them back and to test for return to play readiness. So that's a big one with the easiest correlation for me is literally UCL injuries with NFL players, and what they're returning to is a little bit different, but the testing and training looks really similar. And then I think any overhead athlete like tennis and volleyball, where you're getting similar arm swing motions and valgus loading at the medial elbow, can really help with performance. Looking at the strength, you don't see as many UCL injuries in those sports, but performance is very predicated on forearm strength in both of those sports as well. So I think being able to test more on the performance side, specifically for overhead volleyball athletes and tennis players, I think there's great usage there as well.
Yeah, completely agree. And in my practice, I've had just in the past couple of days, defensive end with a UCL injury, treating non-operatively, and we're just talking about a professional tennis player with a UCL too, and the same concepts apply with regards to the importance of the flexor pronator musculature. Mike, can you talk about how you're using these strength assessments or training goals within your throwers within the organization?
I can't because it's simply on the medical side for us right now.
Yeah.
And so I can't go into detail on what we're doing within the organization, but I'm happy to go into it kind of more practically and how I think it benefits just pitchers in general.
Yeah, or what about practically?
I think a lot of the time, like you look at, the injuries that have happened over like the course of our game, and I don't have any data on this to confirm, but it feels like shoulder injuries have really taken a back seat in terms of how common they are. And I think shoulder injuries are probably arguably more serious than elbow injuries in terms of like its impact on guys' careers going down the road. And you just see far less of them. And I credit the strength and conditioning industry so much with helping shoulders to decelerate and understanding the problem. And it's interesting to see this problem kind of occur because I think it coincides with the stuff that guys are throwing now and have to throw in order to be paid the money that they're being paid by the industry, right? In Major League Baseball, and how that kind of works its way down into college and high school and even with kids, and chasing velocity and chasing stuff so that they, make their team and eventually make the money that they're looking to make. So I don't think the answer is like, don't make these guys as good, right? I don't think that's like, don't let them throw as hard. I think we have to protect the elbow, from where the game is, and involve our understanding of how to apply our knowledge of the human body to baseball in the same way that we did with shoulder injuries. And for whatever reason, whether it be pitch counts and however the industry has tried to attack it publicly, I don't think we've found that answer until the guys from FlexPro Grip came along and tried to and really like highlighted the issue of, I think it's a forearm strength issue. So I believe heavily in that this is the path forward for maybe not eliminating that issue. I don't know if you can truly eliminate it, but at least putting a large dent in how often they occur and understanding them. And I think that specifically just squeezing something, I mean, to Emily's point before, it's just squeezing something with a hand dynamometer or forearm strength in general versus the actual strength of each finger in different directions to make sure that we're covering the strength of muscles that are surrounding the UCL. It just makes too much sense. And then to do it, where you can calculate exactly how much strength and rate of force production is happening and measure it and recalculate a strength training program. So I just think that understanding how those muscles need to be strengthened and applying it to each individual person is a huge step in the right direction for solving that problem.
No, absolutely. And look, we're getting a couple of questions about some performance related topics. And I do know that the folks involved with the company or FlexPro Grip I know that they're willing to set something up on the side to demonstrate some of the stuff that they've done with regards to looking at spin rate and some performance and training side of things, which is not exactly what Toby and Drew, what we're looking at today. And I think that's probably better off if they set up a separate presentation. To be fair, that's actually the first thing that they showed to me was some of the white paper work that they were looking at as far as are these things trainable with regards to spin rate. And that's one thing I liked and appreciated because you got to get athlete buy-in. And I think that many athletes will trade a flash, they'll put stuff at risk for a flash in the pan for an opportunity, right? And so coming from the medical side, although that's where I live and exist, and that's where some of us also live there. You don't always get that. You don't always connect with them, and so I think coming at them from a hey, look, if we can do this, this may have some performance benefit to you. All of a sudden, their ears perk up, and then on the back end, I can say, and also actually, we might be able to do some monitoring and some targeted stuff to try and help you. And so I'm gonna let them present to you guys. If anybody's interested, just reach out to Daryl or Adam, and I'll have them show some of the stuff they've been working on because I think it's a little bit outside the scope of what we're talking about today. But Emily, the other things that you can measure. So importantly, this study with Drew and Toby, we're looking at peak flexor strength, right, in that testing protocol.
Mm-hmm.
But other, people are asking about rate of force development. There's other things that can be tested here, and are you incorporating that into your practice? Emily, do those numbers mean anything to you?
We generally, when we're testing athletes, rate of force development does mean something to me. In particular, when I'm testing forearm strength, FTP, FDS, using the FlexPro Grip, I don't use rate of force development nearly as much as I would when I'm testing things like hamstrings for sprinters and stuff like that. And the reason for that is what we know about the musculotendinous unit of that common flexor tendon is that part of the reason why it mitigates UCL injuries so much is because it minimizes gapping at the joint. And that's specifically mostly a tendon property. So we can measure strength and performance of the forearm, and we can measure changes in that strength and performance. And there's generally three reasons why you get a change in that performance. And it's either a neuromuscular change, so the actual neuromuscular unit gets more efficient at firing, and hypertrophic change in the muscle belly, or stiffness of the musculotendinous unit. All of those can produce strength changes. And the stiffness of the musculotendinous unit, to train that, we largely get those tendinous changes with isometrics. So that has much less to do with the rate of force development as it does with training these longer sustained holds at a high rep max. So greater than 70% rep max, we're going to get those changes in musculotendinous units, tension or stiffness. So it's not that rate of force development in general doesn't matter for athletes, but specifically when we're looking at the forearm, I use rate of force development much less than I use the total strength of that forearm. And then training, we're not doing a lot of like quick ballistic plyometric type stuff that would train rate of force development. We're doing much more isometric, long hold, sustained stuff to try and get that change specifically in the musculotendinous unit, and not necessarily, like I said, that neuromuscular quick firing change.
Yeah, no, I think you dropped a lot of knowledge on us there with that, but I tend to agree, but I think it has to matter to some extent, right? Like I think that all those things are important to be aware of. I don't know how to perfectly use it in practice yet, but it makes sense. There's an underlying muscular stiffness role being played, but there's also a dynamic stability role to be played. So you would imagine that if the rate of force, a thrower with a more rapid rate of force, ability to deliver force, which is what we're measuring with rate of force development, can maybe with poorly sequenced mechanics can maybe recover, right? Versus say as a thrower gets slightly out of their kinematic sequence or has some slight biomechanical change, whether it be fatigue or whatnot, and they don't have that rate of force development, they might not be able to cover themselves in that risk position. So I think theoretically it makes sense. I just don't know how to practically incorporate it quite yet. Question here about acute to chronic workload and its impact on flexor testing, injury rates. One part of this is for Drew and Toby. Any idea where the testing was done with regards to within the season for these throwers?
That's a great question. I can't specifically speak on when in the throwing season it occurred. I do know a vast majority of the drive line participants that were in it were actually at the beginning of their training at the driveline camp. I do think that it is also important to remember, just like statistical test wise, we got to get nerdy about the numbers, by providing like an F test and a Shapiro-Wilks test. It kind of standardizes, if it passes the test, of course, it standardizes the variance and it standardizes the normality between injured and uninjured cohorts. So it's kind of safer statistically to assume that the bell curve between the two is the same if it passes the test. And of course, the variances, so you could include like standard deviation, of course, is a function of variances. They are also equal. So therefore, the spread is the same. So in that way, it kind of makes sure that the injured and uninjured cohorts follow along the same lines there. But as far as specifically talking about like data collection as at time of the season or time of a throwing schedule, it was not performed.
Mike, any comments on acute to chronic workload and with regards to managing your throwers? That's probably a topic for a whole nother hour-long Zoom here.
Yeah, sure, for sure. I'll try to simplify it. I mean, it is extremely important. I mean, just how built up they are. I really like to compare it to strength and conditioning training. Like you wouldn't just go and squat every day as much as you can for the next week. Like you're just going to hurt yourself in that way. So spacing yourself out and causing your body to adjust is really important. And I think there's a lot of talk on workload right now, but I don't know how measured it all is. And that's where acute to chronic really comes into play, is how specific we can get. I will say, I think there's too little throwing and I think there's too much throwing. I've seen a lot. And I was involved in a Washington Post article recently that suggested that more throwing might be the answer. And it certainly could, because you're forcing the tissue to adjust to throwing, right? It's one way to do it. But I think there's more ways to do it. And I think you can do too much throwing in addition to too little throwing, right? We want the tissue to be able to adjust to what you're giving it so that it's prepared properly. So finding that ratio, but also having a blend of the art and the science, and not just going completely on analytics and completely on numbers, and teaching guys to feel what they're feeling within their arms and to when they give themselves a break or when they push themselves, I think is also important. So meeting somewhere in the middle on those two.
Yeah, I think you're totally right. I mean, we see it, I get the question all the time in the clinic about, should we be throwing year round or do we need a deload period? And the answer is probably, for some throwers, they would probably do better off throwing year round, while others might need a shutdown. I mean, everybody's different. And from treating higher, guys, there are some higher level guys that really know how to keep their arm healthy, and some of them just feel better throwing year round. But that doesn't mean that they're redlining year round or they're pitching year round. I mean it, and so, you know, again, this study looked at association, right? So we don't really have that predictive factor, but that's the value of some predictive factors if we have them, right? We can use it for monitoring to help throwers as they're guiding through this part, right? Can I keep throwing or do I need a deload? Well, if we know that there's something that we can watch, right, that increases your risk, that might be an opportunity to intervene. Look, we're going to have to peel you back from this and we're going to target your rehab in a certain direction. Right now, we don't know that for sure based off of this data, but we do have some suspicion that this ratio matters to some extent. Whether it's an association or predictive factor, it's an association. Whether it's a result of injury slash surgery or if it's predictive of injury is yet to be determined. Emily, what are your thoughts on that?
I'm sorry, you cut out just a little bit at the end. Can you repeat the last part of your
Oh, I'm sorry. Sorry about that. What are your thoughts on utilizing potentially predictive factors for as you're guiding athletes on whether they can how to tailor their volume? Do they need more volume or less volume to progress as an athlete?
Yeah, I land a little bit more on the spectrum. Most throwers probably need to be throwing a little bit more than they are, and I for some athletes, but I think you have to take the full athlete profile into consideration, and you have to look at injury history, what they've been doing, what their current strength and conditioning program is like, and it's a hard one. It's really a hard one. But when we look at hypertrophic changes versus muscle loss, when we shut down, it's a 3-to-1 ratio, right? So we lose muscle mass 3 times as fast as we gain it. So when we're fully shutting down, I think a lot of times we actually don't give guys enough time to ramp back up. So then we're in an underuse situation and guys are not prepared for the loads that they're throwing. And so then that's where you get into the acute versus chronic workload issue, because in the acute, it's too much workload. But if you look at the chronic overall picture, they were underprepared. But because they were underprepared on the longer term scale, they had an acute workload issue. So we see all these elbow injuries that look like in the moment acute workload issues. So we think that we need to throw them less and be more protective of the elbow. But really the issue is they were underprepared and they weren't throwing enough. And they wouldn't get to the point where they got to build up that endurance for what they're doing, because it's a marathon and a sprint for throwers, right? Like it's a marathon in that it's an 8-month season if you're including spring training and things like this, but it's a sprint in that in the moment it is a singular max effort ballistic situation where you get anywhere between a minute and a minute and a half to rest in between pitches. So I tend to be biased a little bit more towards, I think a lot of our long-term throwing programs need to increase the chronic work to decrease the acute workload issues, if that makes sense.
Absolutely. It looks like we got visuals on Gunnar here. Gunnar.
Yeah, and I really apologize. Sorry that I had one of those drives that was it couldn't make it up. The right lane was closed and the left lane was closed, and there was a disabled vehicle, and then once I got off of 77 on 81, there was another disabled vehicle. So I apologize. I was able to listen to the entire presentation. I just want to say great job on the presentation and lots of also really great questions here. I'll just add in that we are also here at Virginia Tech, we do have a small prospective study going, and we're looking at, I guess, tissue changes related to the use of the FlexPro grip device. In other words, looking at elastography as a specific ultrasound technique that can be used. We have really high-end research grade ultrasounds, and so that's one of the things we're looking at is what about tissue stiffness? As Emily mentioned it, there's active and passive restraints, so to speak, and so I think that's helpful from that perspective. And hopefully, as we get more data, we'll have more insight onto this aspect of, is the ulnar collateral ligament affected by a training program? What about the specific muscle tendon units? And then the other thing that I'll mention is a concept that's kind of general, but just the whole idea of integrated isolation. In other words, we're isolating these specific muscle tendon units, looking at the strength characteristics that they have, but they also have to function in an integrated way in the forearm in order to successfully pitch a baseball. And I think that's a concept that works for lots of muscle tendon units and the joints that they influence. So that concept of integrated isolation, and I think this device is something that allows us to get at that in a way that we've not been able to do before. And just to close the loop on the whole conflict of interest, if friendship could be a conflict of interest, I've known Daryl and Adam for the better part of 40 years. And so we've been friends for a long time, but I don't have any financial conflict of interest. So just letting you know that. And thanks for the great questions and putting this seminar on. And thanks to all the panel members. And again, sorry I was a laggard, but appreciate the opportunity at least to get in the tail end of this.
There you go. Well, thank you, Gunnar. Sorry that you had the rough travel, but I'd like to, wrap this up. We're at the top of the hour here. So, again, Toby, Drew, thank you for presenting your work here. Great work. I think we're leaving with more questions and answers, which is exactly how this should be, right? This should stimulate some thoughts and stimulate the next wave of research. Thank you, for Emily and Mike for sharing your expertise, for joining today. Thank you for all the great questions in the chat. There are a few things that we didn't quite get to. We're going to circulate this to our panelists and our authors here to go ahead and answer some of these questions, and we'll recirculate to everybody who's joined. But again, thank you for joining. Thanks for everybody's passion here. I know we're all pulling in the same direction, just trying to help our throwers sort of pursue their next level of performance while also keeping them healthy and putting them back together when things go awry. So thanks again. I hope everybody has a great rest of the day. And then until next time, we'll see you later.